did. Is it a good aesthetic makeover? No. Why? Smile arc is not followed. When you see the angulation here, there is a difference in the angulation of your maxillary central incisors. And you see slight canting also. So I will consider it as an unaesthetic smile makeover after going through all my components. Is this an attractive smile? Yes. What is lacking? Reverse smile arc. Is this? No, because gumminess. Lip line is high. So here you can see that there is a lateral incisor, central incisor, they have this kind of a relationship which is ideal and it should be there. Whereas here what you see is, it is too much higher in comparison to central. Lateral is higher. Whereas in this case what do you see? All are in the same line, giving a box-like appearance. So it is anesthetic. Here the golden proportion or whatever the proportion is not followed at all. Laterals are pec laterals. So here what is lacking? Central is considered to be okay smile. Both the other smiles are not okay because they are not following the smile arc, and lip line is also not okay. Here the canting is present, that's why it is not good. So let us go ahead with few of the case series to see how we can improve the smile. Here is a case wherein which you see when the patient is smiling, though it looks like as though it is following smile arc, no it is not. It is actually trapping the lip. Lower lip is little bit trapped, and here you can see it much more pronounced in this picture. Here you can see that it is much more pronounced. The incisors are covering the lower lip, and in this region also you see that incisor exposure is more during the rest, and it is also covering the lower lip. This was the dentition. We have class 1 molar as well as endonish canine relationship. What we did was we went ahead and did the 4 premolar extraction along with the MBT technique. We used 3-piece inclusion to correct it, and what do we see right now? This is the picture of the patient wherein with the incisor exposure is completely reduced in the frontal resting position. When you see here the smile arc is followed. Is it smile arc is followed? No or yes? Yes. Then you can see that the profile is also improved. The lateral inclination as lateral in the sense in the lateral view, the inclination of the incisor is completely corrected. Going to the next case. This is the intraoral picture. Class 1 canine, class 1 molar, decreased overjet. We see that midline is not completely matched, lower is little bit shifted, but it is okay because our canines are in class 1. Going ahead, next case, this is a bimaxillary protrusion case. Again, you see that the incisor exposure is more during the rest as well as smiling. You don't see a consonant smile arc here. Gumminess is more in this patient. Even the lateral view shows the same thing. This was the intraoral picture. We did all 4 extraction. Used the pads to retract the maxillary anteriors. This is the post-treatment picture. This is after following up for 5 years. What do you see here? Our smile arc is improved. Our midline was not matching initially, but now it is matching. And we have given a good orthodontic smile, that is molar to molar smile we have given. There is no negative space at all. Prosthodontists might feel it is not a good smile, but for us it is a good smile. This is the intraoral picture. Again, here one more patient. I feel that it is reasonably okay considering the malocclusion severity here. We could achieve this much smile. I am okay with it. Why? Let me check out and show you the intraoral picture for the patient. See here what has happened. The laterals and canines are transposed. We have a retained deciduous canine here, and on both the sides the canines were retained. In the lateral space we have the canine, and in the lateral we had the canine, and in the canine space we had the lateral. We had to do the treatment. That is why the patient ended up here, but still we could create a reasonably good smile for him. Going ahead, this is another case, lip trap, We have buccal corridor area, which is negative. And then, how did I treat? This is a class 2 malocclusion. So what we did was, we had two-phase treatment here. One, growth modification using myofunctional appliance, that is fixed myofunctional. We had Herbst appliance along with the RNA, followed by which we went ahead and did fixed orthodontic treatment, and we could achieve this result. Overjet completely decreased, class 1 canine, class 1 molar. Pre and post treatment picture comparison for you. Again here, you can see that we achieved a smile arc, the gumminess is reduced, and we can see the midline is also comparatively okay, and buccal corridor areas are, I think, comparatively okay, because it is our case. But we didn't take care of the buccal corridor area, though we gave RME for this patient. This particular case won the first prize in clinical innovation category of orthodontic conference. This is one more case. This is class 2 due to case, wherein which we went ahead and did both the myofunctional as well as the fixed orthodontic treatment. This is the bars appliance used for bringing the mandible forward along with the headgear. This was the first phase treatment. After that, what we did was fixed appliance treatment, phase 1. This was the phase pre-treatment, phase 1. Then we have the post-treatment phase. You can see that his smile is better than what he used to smile here, isn't it? So, orthodontic treatment can do wonders. This particular case again came as an article in Asia Pacific Orthodontic Society's journal. One more case. This is a smile wherein which you don't see the display of incisors at all. So, going ahead, it was a crowded case, and one lateral incisor was completely tucked inside in the lower. We went ahead and did the self-ligating bracket system treatment for this particular patient. So this is the post-treatment. We came up with a non-extraction treatment. We had increased the space. We had come up with a good incisor exposure for this particular patient. This also came in Iranian Journal of Orthodontics as a case report. One more case here. Again, canines are highly placed. We used non-extraction treatment by molar discalization, and we could achieve this smile for this patient. How many of you are more interested now to take up orthodontics as a branch for your post-graduation? Good. So let's see the next case. This is incomplete case, but I still wanted to show it because here what you see is a reverse smile line. You also see, what you see is a deviated midline due to angular shift. So, and we also checked out for gumminess, check for the gumminess, how much is the gum exposed. In males it should be only 0 millimeters, that is interdental papilla only should be seen. But here you see a lot of gum. So what we did, we went ahead and did tats for him, that is fixed mechanotherapy along with tats. So what did we achieve? We could decrease his vertical proportion. Along with that, this is how the patient is right now. What do you see? The gumminess is completely gone. You also see that the reverse smile arc is getting corrected. Can you see? From ear to ear. So, followed by that, you have one more case, incomplete but still. This also is treated with TAD. What you see right now is this patient having a reverse curve along with gumminess, and now there is no gum exposure and reverse curve is getting corrected. One more patient with class 3 malocclusion here. We did simple face mask with the white plane. We could achieve the result in this manner. This is the interdisciplinary approach wherein which this patient had trauma to his central incisor. We went ahead, he had multiple spacings also. We corrected using orthodontic treatment of multiple spaces, and then with the prosthodontist aid we came up with a post-and core and we ended up with this result here, as you can see. Similarly, the intraoral pictures for you. And without any orthodontic treatment, one of my friend, periodontist friend, just did the gingivectomy to give this particular patient a beautiful aesthetic smile. So you can become periodontist also to give a good, beautiful smile. Then here is another case wherein which there was peg lateral. So what we did, using our TR proportion, what we had proposed earlier, using that thing, we built the lateral incisor. Look how beautiful the lateral incisor is looking here. Same thing, using the same proportion, again we went ahead and in this particular patient, peg-shaped laterals and crossbite was there. So we did RME treatment. Along with that, we also built the lateral incisor using our PR proportion. Same way, the next case is also built in the similar manner. To conclude, smile designing is an interdisciplinary approach and it requires the aid of restorative dentist, orthodontist, prosthodontist as well as the periodontist, sometimes oral surgeon also, so that we can achieve a good aesthetic smile. And my topic in the beginning itself was the components of the smile and achievable goal. I hope we can achieve by the way I showed the case series. I hope you are instigated and believe with me that these are the achievable goals. These are my references. Thank you. If you never try, you never know. Kindly do try.
Thank you, Dr. Tarulta. That was a wonderful presentation. And Madam is actually a professor and actually in a college, and the way she took her presentation, it could show that she's a teacher. You know, the way she was taking it and asking you all questions. So it was very nice. We really enjoyed it. So is there any questions you all want to ask her? Very nice presentation.
Thank you, Taruna. It was a nice presentation and it's an eye-opening presentation to us. And I like to call Jodhindran sir to deliver the momentum. And the moderators are instructed. May I request the Jodhindran sir to give the memento to the moderators.
Special pleasure to Professor. Very good.
Moving on to the next session, I like to call like to intro the Arnima ma'am. She was done her undergraduate in Rajas Middle College of College and Hospital in 2001. In 2007, she done her PG course in Sri Ramachandra Dental College, and her current, she was a professor of PMS College in Dental Science in Trivandrum. She was doing so much of research and ongoing papers. I kindly welcome you, ma'am, for moderating the session. I'd like to intro the Rachimol. She is professor in the Department of Periodontics in PMS College of Dental Science and Research. She done her bachelor degree in Rajas Middle College and masters in periodontics and oral implantology in the Annamalai University. Currently pursuing the BSc in Kerala Institute of Health Science, have various national and international qualifications. I'd like to welcome you, ma'am, to moderate the session. It's my privilege to invite and welcome the Bhagavad Gita ma'am to deliver her speech. She was an academic and passionate clinical research and practiced the periodontist with an experience of 31 years. And she was done her bachelor degree in 1991 at the University of Madras. She was the principal in Mata Dental College and Hospital in 2023, and she was doing the research scientist voluntary research in Chennai Dental Research Foundation, Mylapore. She is the educator of the thesis of doctorate in science for the Sri Ramachandra Institute of Health Education and Research. She is invited the keynote speaker at the Saliva Symposium International Conference held in Bangalore in February 2020. She was invited as a keynote speaker in 15th Indian Society of Periodontology National Postgraduate Convention, Bhubaneswar, 12th and 13th March of 2016, and Best Teacher Award in SRM University in 2006-2007. And professional membership in Indian Society of Periodontology. I'd like to invite you, ma'am, to deliver your speech. Thank you.
Very good afternoon to all. Am I audible? It's audible now? So, very happy to be here as part of this 34th annual conference for the Indian Society for Dental Research, ISDR. And I think after a very clinical and aesthetic topic, this is a paradigm shift into a more of, I would say, a research-based presentation. But I would also like to say that I am going to discuss how this is going to have clinical implications. Before I start, may I know what kind of audience I am speaking to? Yes? How many academicians and faculty and PG students here? Can you raise your hand? Okay. And purely clinicians? No. Okay. Those who are doing some kind of research, PGs who are doing their dissertation, any PhD candidates? No PGs here, it's all faculty and academics. So which discipline you all belong to? Pardon? Periodontics. Okay, then you should have put up your hand. So what is your thesis work about? What is your MDS dissertation about? Okay, then let it be interactive. We should all come out of the slumber of our afternoon lunch, right? And I don't think my topic is going to help if I just start off with all the organisms, names and diseases, and let's make it a little more interactive so that both of us are ready to face the lecture. Yes? Others? Okay, fine, okay. As long as I've woken you up, I think I'm happy. Okay? So, see, my topic, as you would have seen, is periodontal medicine, a century. So this title obviously says that, yeah, this has been happening for a century. Something about this. How many of you know what is periodontal medicine? Any idea? I hope the periodontists at least know it. Are you a first year student? And you look clueless. Am I right or wrong? You've heard of the term periodontal medicine? I think it's there even in your undergraduate curriculum. So basically, before I start this, I just wanted to share something. When I was doing my BDS, maybe in 1991, I gave my final year exams. And I think all of us to this day, when you give your exam, you look at the previous year's question papers, right? The last minute, you just want to read something to make up for the not studied portions. Okay, at least let us see that the last 5 question papers, last 5 years papers have been covered. Okay, and rest of it sometimes we ignore, especially as the exams come close by, and I think it has helped us by and large. So most, at least 75 to 80% of the questions are repeated. So similarly, when we were doing it way back in 1992, we used to come across a question called bone factor concept in our perio paper. I was an undergraduate and nobody was ever taught us about it. It was not there in our prescribed textbook. At that time we had Glickman. I think now it is Carranza. Glickman is a legendary person. He is no more now. I think my respected chairpersons will be knowing that. So we thought, okay, fine, what is this bone factor concept? Nobody knows about it, our teachers don't know, we don't know what to do. Then we somehow spoke to our seniors and they gave us an old book. I think it was with moths and we had to retrieve it from some corner of the library. They said, go see that 3rd edition or something. And there it was, Glickman's bone factor concept. So finally we got a clue. We quickly took that, we wrote about 3-4 lines from that, we prepared one short note, because it used to come only for a short note. And that was the end of it. I don't know whether we even got that question or not, but that was my first exposure to what is now before you as periodontal medicine, which is such a very research topic with a lot of clinical application. It is growing by leaps and bounds. Okay, so this bone factor concept was nothing but a very small idea that probably your oral health, particularly periodontal health, may have a bearing on few other systemic diseases. So I think this is something that most of us are aware of, but many of us think, is it much ado about nothing? Does it really matter? Are we really going to treat patients with this worry that they are going to be at a risk of developing a heart attack just because they have poor periodontal health? I think all of us, including periodontists, have this question when you look at it from a clinical perspective, right? So before you, I'm just going to unfold the journey of periodontal medicine, what it was a few decades ago, what it was sometime earlier, what it is now, and what way it is going to help us improve our patient care. You can see, according to the global health estimates in 2016, ischemic heart disease tops the list of global death, followed by, of course, the cerebrovascular accidents. COPDs, I think after 2020, they must have taken over after your pandemic, because those with poor vital capacity and poor lung capacity are definitely more prone to COPD, Alzheimer's, diabetes, etc., etc. Okay? So this is the global trend, and probably even in 2020 when I checked, it was pretty much in the same order. But what about India? I think you saw diabetes was somewhere low there, but India is alarmingly, as we all know, I think we hear it everywhere. It is very soon going to be the diabetic capital of the world because of our, unfortunately, we are a developing country, so we have both non-communicable diseases as well as infectious diseases are still prevalent. Okay, so this is something quite alarming because it impacts the healthcare economy of our country. We have to spend for all tuberculosis and whatnot, simple infections. At the same time, these kind of diseases which are very expensive. You know, a diabetic has to take their medicines till the end of their lifetime. Similarly with hypertension. So the global care, the health care of the country is also going to be very expensive. And according to this study, I think it was an update of ICMR in 2023, they have said that almost 10 million people or 10.1 million people in India are diagnosed as diabetic currently. And that's not a very small or a pretty number. Again, the CVDs, deaths due to cardiovascular disease, I think we know very well, especially after the pandemic, we find a lot of unexpected myocardial infarctions, especially in youngsters. And we are wondering whether to attribute it to the COVID vaccine. I think all this people are pretty aware of. We don't know, maybe down the line a lot of research is happening on that. We'll know based on that. But one again very troublesome statistic about this is that the age-related prevalence of cardiovascular deaths globally is only around 233 per 1 lakh. Whereas in India it is about 282 per 1 lakh. So even in that we are beating the world statistics. And another very worrying thing is that it is more towards a younger trend of age. Low birth weight, yes, we are definitely a very much more developed country now. But still, in spite of very proactive efforts being taken by our government, state as well as the central governments, we can say that patients or children who are born preterm, that is before 37 weeks of gestation, as well as low birth weight, 2.5 kg and below, they are definitely at least around 3.5 crores. Okay? And children who die of complications below the birth related complications like your low birth weight, preterm, associated complications with that are below the age of 5 are also about 0.3%. So all these things show us the global statistics and our statistics, how much they differ. Okay? Where does periodontal medicine come here? So here it comes. Periodontal disease, the prevalence, I think you know prevalence of any disease is the number of cases that are there at any one point of time. Okay? So when in 2020, this is a systematic review it's a reasonably decently done one. Probably around 1 lakh of patients have been screened, and they found that almost 51% of patients had some kind of periodontitis. So once again, the prevalence of periodontitis is very high. Even in India, by 2023, even when we feel that the quality of living and everything has increased in our country, and this includes a lot of metropolitan cities. I'm not talking about any rural areas alone. Okay? Okay, so what is the connection between all this? Yes, there is a connection. All these are non-communicable diseases. And what do you think about cardiovascular disease? What is the cause of cardiovascular disease? Can somebody tell me? Yes? Cause of cardiovascular disease. Yes, it's just a casual dialogue between us. Yes, sedentary lifestyle, dyslipidemia, yes, smoking, diabetes, obesity, isn't it? So the common link between all these conditions are these factors. So periodontitis also, as you all well know, have a number of risk factors which are pretty much the same that you mentioned now, except that it is going to be purely initiated by a dysbiotic biofilm, right? Unless there is plaque, there is no periodontitis. Even though there is a lot of research happening, when I studied, probably only plaque was attributed to causing periodontitis. Now we know it is only a initiating factor. There are a lot of other factors, to the extent that periodontitis is now called as a syndrome, because there are so many factors which contribute to it, and it manifests in so many different ways. So this periodontitis has been linked to all the aforementioned conditions that I spoke to you. So the purpose of the focus of my talk today would be how they are connected. Are they really associated? If they are, what are we going to do about it? Is it really going to impact our clinical practice? Okay? In fact, I should say more than 50 diseases have been associated with periodontitis, but most of them don't have much of any evidence. So let us restrict today's discussion about these few diseases. Yes, to be a scientist or to be a researcher or to be somebody who has some kind of focus for you to go. You don't have to be a big very brainy person. You don't have to be a big mathematician. You don't have to be the topper in your class. You don't have to be called with a high IQ. You just have to be curious. So when you're curious, your answers immediately come. So guess who said that? I think we all know he was a very mediocre student, and you know the name he's made for himself. So this is what I was telling you. All these diseases have been linked to systemic inflammation in remote sites. So when you have systemic inflammation anywhere in the body, all these are triggered. So it could be gastrointestinal disease, pregnancy complications, respiratory disease, diabetes, heart disease, cancer, anything. So the objective of my study, of my lecture today is very simple. Okay, I am just breaking it into 3 parts. Understanding the pathophysiology, so why this is happening. See, an association is there, okay, that is proven. For the past more than half century, the associations were studied and it was all proven. Yes, there is an association independent of other factors. But why? What is the association? The pathophysiology has to be understood. And I think all of you know what is evidence-based, isn't it? You need some scientific, what is the top of the pyramid in evidence-based dentistry? Systematic review. So even whether systematic reviews are really contributing to this association. Finally, what are the applications? Whatever we do, whatever we research, finally I think it should be going to our patients, right? So are they going to benefit by this, or we are just doing this just for the sake of finding out associations and churning out numbers, and probably all of us being in academia, maybe we have to publish. Are we doing it just for that, or is it really going to make a difference in future? And of course, what are the future perspectives of this periodontal medicine? What is the pathophysiology? This is always a question that we have. Is periodontitis causing diabetes, or is diabetes causing periodontitis? It's a chicken egg syndrome, okay, always. But, I think how many of you are familiar with the Bradford Hill's criteria of causality? Something can be casual or it can be causal. We don't know. So that's why Bradford Hill, he is a statistician. He has mentioned a number of criteria such as biological plausibility, sensitivity, specificity. I am not going into all that now. But if your study is able to fulfill all those criteria, you can definitely say that the association is a causal one and not a casual one. So what is the pathophysiology? For you to understand all the diseases I am talking about, if you understand this diagram, it's more than enough. So what does it say? You can see that there's no pointer, right? Is there a pointer? Okay. So in this picture, you can see that the culprit, of course, is the tooth here with the biofilm sticking onto it. And from there, you can see there are 3 arrows going. Can you see that? So one is causing systemic bacterial dissemination. What do you mean by that? The bacteria, any periodontal pathogens, can anybody name? Okay, so it can be Porphyromonas gingivalis, which is very, very commonly associated with systemic conditions. It could be Fusobacteria, so many others. I would say more than 700 species are there now. So these bacteria will get into the bloodstream and they physically reach all the organs. So what I am saying is, when a patient undergoes a CABG or coronary artery bypass graft, these Porphyromonas gingivalis and periodontal pathogens have actually been taken from the end arterectomy specimens. So that is proof enough that the periodontal bacteria travel through the bloodstream and they reach the heart. Similarly, when they swallow, what happens when they swallow? When this biofilm is present in the mouth and swallowing happens, it leads to dysbiosis. So what do you mean by dysbiosis? When the biofilm is very uniform, it is not having this is a very simple explanation I am giving you. Dysbiosis itself is a lecture by itself, so I am not going into all that. So when you swallow, the gut bacteria, which are normally very eubiotic or symbiotic, they get dysbiotic. That is, they are very disarranged. They become more pathogenic and they are able to cause more of disease. So they become dysbiotic. And thirdly, all the pro-inflammatory markers like your tumor necrosis factor, interleukin-1 beta and IL-6 all increase. They in turn act upon the liver. I think you all know liver produces a lot of C-reactive proteins. They are all acute phase reactants, they are called. Immediately when there is an acute inflammation, all these are triggered. It releases this. And this so the whole body is put into a factory of inflammatory mediators. So you can imagine from the gum, then gum goes and triggers the liver. It creates a lot of mediators, and on the other hand, you have your bacteria also directly reaching the organisms, the far placed organs such as your uterus there, your gut, your liver, your heart, and they promote the various diseases that are associated with these organs just by one simple word, inflammation. So if you understand this is the basic pathophysiology for all the other diseases. This is another picture. I am not going too much into it. This is a homeostatic polymicrobial biofilm. I told you when the biofilm is in a good healthy state, it is homeostatic. When it becomes perturbed, it becomes polymicrobial, acute inflammatory, and finally it's a dysbiosis when it is a chronic inflammatory lesion. And as you can see here, in healthy state it is homeostatic, and in a periodontitis state it becomes dysbiotic. So I am just adding a few slides about the various clinical pictures that you may see for you to understand. First of all will be the oral health in the female patient. I think you know this is a case which we have seen and we have treated. I am not going into the treatment part now. This is a pregnancy tumor. You know, when the patient comes to you like this, it's very alarming for you as well as the patient. But there is nothing to really worry about. I am not going into the treatment aspect as I told you. You can treat the patient probably in the second or third trimester if it has to be. You know, sometimes it's very difficult for the patient even to eat, and they have this kind of a situation. It bleeds very badly, they can't even close their mouth properly. And when a pregnant patient doesn't have a good nutrition, we know where it takes them. So we may have to treat them under such conditions. And this is another condition. It's a puberty gingivitis case. So basically I am showing you these pictures just to say that, have you ever wondered why the gingiva or the gum is always a target for these hormone related changes? So one is, there are a lot of estrogen and progesterone receptors which are present in the gingiva. So whenever there are some changes in levels of estrogen and progesterone, as in these conditions, the bacteria, particularly Prevotella intermedia, which is present in the gingiva, it gets triggered and it starts using these hormones as their metabolic products. So instead of using vitamin K and any other metabolites which they use for their growth, they start using this estrogen and progesterone which are in high numbers. So this hormonal imbalance does not spare postmenopausal women as well. You know, when there are postmenopausal changes, there are shared risk factors. As I told you, periodontitis does not cause this alone. It always has a lot of confounding factors like age, genetics, hormonal changes, smoking. Of course, you know that once you are postmenopausal, your estrogen levels drop drastically. So your calcium absorption is also less and vitamin D also goes down. So this leads to a net systemic bone resorption, loss of trabecular structure and loss of skeletal strength, as you can see in the picture, there could be also a fracture. I think we all know postmenopausal women are prone for fractures. Of course, the famous twin sisters, periodontitis and diabetes mellitus. I think even non-periodontists or people who practice will know very well about this bi-directional relationship between this. This is a very classical presentation of a severely diabetic patient with a poor periodontal health. I think the first thing which comes to our mind when somebody has multiple periodontal abscesses is look for whether they are diabetic. Either ask them, if they say no, we are not, definitely we go in for a blood sugar estimation. Inflamed, bleeding, enlarged gingiva. Some teeth may even be mobile. You take a radiograph, there is very evidently bone loss there. Delayed wound healing, you do an extraction, the patient comes with some kind of disturbance. You are not expecting the kind of healing which you are expecting is not happening. So what is the pathophysiology between diabetes and periodontal disease? As you can see, it's a two-way street here. So diabetes, of course we know it causes hypoglycemia. That again leads to defective neutrophil function, basement membrane thickness, and it releases advanced glycation end products. The advanced glycation end products lead to defective collagen synthesis. And I think we all know that when there is a defective collagen synthesis, your periodontal health is again going to be bad. So again, the receptors for advanced glycation end products are there in your neutrophils, macrophages and monocytes. They in turn secrete a lot of pro-inflammatory cytokines that leads to destruction of the cells of pancreas, that leads to insulin resistance, and it goes on like that. It's a vicious cycle. Okay, so this is a very intricate web of periodontal disease and diabetes, which all of you have to keep in mind, whether you're a clinician or whether you're going to be a periodontist or you're going to be a researcher or a faculty, whatever. When you think of the patient, probably even you should sensitize the common man with this. Okay. Of course, respiratory infections have come to the forefront after our COVID pandemic in the past 2-3 years. So periodontitis has been considered as one of the factors which could increase the risk of respiratory infection even before the pandemic, much more now. Commonly they have been associated with COPDs and pneumonia, and now the SARS-CoV-2 infection has also added into the list. So what happens? How does your SARS-CoV-2 cause or not cause? How is it associated with periodontitis? Or how do patients, I think a lot of studies have been done, which I am going to quote now, as to how poor periodontal health has been seen in patients with severe COVID infections. You can see there is a SARS-CoV-2 infected individuals. They have an aspiration of the periodontopathic bacteria, and as we know, I think the ACE2 expression has been the route of entry of the SARS-CoV-2 virus into our body. I hope you all know that it is there in the salivary glands, it is there in your oral epithelia, so a lot of them are found in the gingiva. So why do you think the patients had xerostomia? Only because of these receptors which are present in the salivary glands. So this leads to increased ACE2 expression that causes an induction of the SARS-CoV-2 infection, increases pro-inflammatory cytokine production, and exacerbates the pneumonia which is already happening. So this, if there is a good oral hygiene, your periodontopathic bacteria are not going to be present in large numbers and they will not get aspirated. So these are two of the studies which were done by me and my team. So the first study was when SARS-CoV-2 antigen in whole mouth fluid. So whole mouth fluid is nothing but saliva, that's how it is called now. So it is found, it may be a reliable rapid detection tool. So when we didn't have vaccines and when we didn't know which patient of ours had asymptomatic COVID infection, the saliva kit, I think we all know there was something called as the rapid antigen test kit. So this this study was based on that, and it was found that the rapid antigen kit using saliva was very effective in detecting whether the patient was COVID positive or not. And also another study which we did in our group is the implications in the quantification of the COVID-19 virus in nasopharyngeal swabs, saliva and respiratory droplets, and it was found that in saliva the copies were as many as found in the nasopharyngeal swab as well as respiratory droplets. In fact, in severe early stage of COVID infections, when the patient had to be hospitalized, the copies were more in the saliva. So this shows that our oral cavity is definitely going to be a source of or can be a reservoir for the SARS-CoV-2 virus. So now that the pandemic is over, we've all, I think repeatedly we are getting the COVID infection, we don't even bother to check. But still at that point of time it was something very important to us. These are two studies. So these are two studies, a case control study on the association between periodontitis and COVID-19, which was a very small study of about 72 patients, which found an association that patients who had COVID-19 had a poor periodontal status. And association between, this is a very interesting study which was published in the Journal of Clinical Periodontology, where they retrospectively checked the periodontal status of patients who are in the ICU, that is those who are admitted for COVID but they were severely infected, probably some of them even died. It was found that they had a very severe periodontal destruction as well. These are the two studies which are worth talking about. So pneumonia and periodontal disease can occur due to gut bacterial regurgitation, aspiration of the upper respiratory organisms and oral cavity organisms into the lower lung, which is exacerbated by poor oral hygiene. This is again, COPD is something which is quite common. It's getting very common after the COVID pandemic. Association and potential mechanisms, I don't want to repeat it. They are pretty much the same. That's why I told you, if you look at the second picture which I showed you, it explains the pathophysiology of most of the diseases associated with periodontitis. Of course, you have a lot of confounding factors also here. Common risk factors like your smoking, pollution, poor socio-economic status, poor dental habits, etc. Periodontitis and cardiovascular disease. It's once again the same pathway. You have the periodontal pathogens. Either the bacteria directly enter into the system and cause atheroma by increasing the viscosity of the blood, or they could also elicit a host inflammatory response as seen in the second thing, increasing the levels of pro-inflammatory cytokines, thereby causing the rupture of the vulnerable plaque, leading to a myocardial infarction due to atheroma formation and thrombotic dislodgement. As you can see, the smoking, the genetic predisposition, environmental factors are all very common risk factors to both periodontal disease as well as cardiovascular disease. Hypertension, again, I think we know hypertension is becoming very prevalent in India because of the kind of diet we have. Very even late 20s, I see a lot of people who have hypertension. So that again, the reasons are systemic inflammation, sympathetic nervous activation, and bacteremia directly going into the vessels, causing perivascular inflammation, increasing the oxidative stress by causing releasing more of reactive oxygen species. And along with that, when you have your classical symptoms like obesity, stress, increased intake of salt, etc., there is a chance that hypertension is going to be happening. So periodontitis never causes anything by itself. Please make that, I hope I made that clear, understand that. Metabolic syndrome, I think you know what is metabolic syndrome. In fact, this is the next future. It's called MedTest. And it has 4 components. So when any of these 3 components are present, you can say that the patient has metabolic syndrome. Your high triglyceride, low HDL, hypertension, insulin resistant, visceral obesity, and of course diabetes. This is again a picture which is showing how periodontitis can cause obesity, again by the release of adipokines, which are again pro-inflammatory cytokines, and hyperinsulinemia and insulin resistance. Rheumatoid arthritis, again there are three pathways by which periodontitis could increase the risk of arthritis. One is infection and inflammation, leading to citrullation of protein. So that is all a very biochemical term. I am not going into that. Probably the perio PGs may make some sense out of it, but I am not going into it for the general audience. So citrullation is a biochemical process which happens, which leads to increased inflammation, particularly by Porphyromonas gingivalis, which is called as a keystone pathogen. Then common inflammatory pathways are also triggered, and this two-hit model of mutual exacerbation. So there are periodontitis and rheumatoid arthritis exist together, and the mutual exacerbation is caused by the side-by-side existence of both the conditions. Alzheimer's disease. Once again, you know that now the life expectancy is increased very much above 70 years. And as you grow older, your blood-brain barrier becomes more permissible to a lot of chemicals. So based on this, it is found that when you have a periodontal inflammation, it can get into the systemic inflammatory cycle and then lead to trigger of these amyloid beta plaques being formed, and tau protein is something that plays a role in tau fragmentation, which plays a big role in Alzheimer's disease. In fact, we have even done a study on the level of this tau protein and the association with P. gingivalis. The results are yet to be published. Oral cancer, once again, as I told you, the key link is inflammation. So oral cancer has also been associated with this. I am not going into that much. Then of course, without plaque, without bacteria, there is no periodontitis. So what is the role of the oral microbiome in periodontal medicine? So as we know, I think it's not only about the bacteria or the virus or whatever, it is about the host response to these organisms. So unless we know what are the pathogens which are going to affect us, the body will not be able to fight the infection, just as we faced in the COVID-19 pandemic. You have to understand the role of the microbiome, because this is the kind of close association we have with bacteria and viruses ever since the time we are born till the time we leave. So you can see that, in fact, we can say that we have two genomes in our body. One is our own genome and the second is the genome of the microbiota which are present in our body. So the life stages, you can see when the child is just born, gradually the microbiota are not very diverse. There are very few microorganisms. And as he grows up into a male adult, and then an adult, and then slowly as they go into their older age, you can see that a lot of environmental factors come into the picture, such as the oral hygiene practice, what food you eat, whether you have stress, do you have other environmental factors, such as smoking, what are the medications you take. So all that completely determines the diversity of your microbiota as you grow older in age. And finally, the systemic diseases and conditions have certain signature microbial organisms. So like a signature, it is said that in diabetes these organisms are found. So that is what has been found by these studies. So I told you what is eubiosis, when there is a very passive state. In this biosis, there are a lot of pathogens which lead to inflammation and periodontitis, which in turn can lead to many of the conditions which I spoke to you now. When you have more of pathogenic microbiota, it increases the risk of caries, periodontitis and systemic diseases. And our periodontal pathogens like Porphyromonas gingivalis and Fusobacterium nucleatum have been found in patients with head and neck cancer and even colorectal cancer. So what are the oral microbiome signatures? We see in diabetes mellitus and periodontal disease. So bacteria, which the first figure shows patients who had a normal glucose tolerance. Second is pre-diabetic patients, and the third is the patients with actual diabetes mellitus. And it is, you can see in each group you have different kind of bacteria. So in the group with diabetes mellitus, you can see that there is more of bacteroidetes as well as fusobacteria, whereas the healthy group you have more of your actinobacteria and proteobacteria. So what I am saying is different type of periodontal disease states have different type of pathogens. Similarly here you can see the picture looks very overwhelming, I know, but still you can see that based on whether there is gingival bleeding, whether they are pre-diabetic or diabetic, the type of bacteria which are present and the copies which are expressed are different. So it's not that all periodontal bacteria will have only this. So when there is more bleeding, you have a different set of bacteria. When there is higher probing depth, you have a different set of bacteria. So that's how it works. Even in cardiovascular disease, different bacteria have been isolated from the atheroma. And in oral microbiome and preterm birth also, there are some specific species such as Prevotella, I told you, Capnocytophaga and Bayonella, which are found to be present only in the parents who have the preterm birth babies. So I told you, without much of evidence, we cannot come to a conclusion. So I am very quickly going to rush through some evidence. This is what happened. This is where the century comes in. From 1900 itself, it was found that the oral cavity was a source of focal infection. William Hunter was the person who pioneered this in 1900. So the thing went on very well. So all dentists were considered as gods because all diabetologists said, and people who were treating rheumatoid arthritis patients said, yeah, if you get your teeth extracted, you are going to be fine. So please go and do that. So that's the importance that the focal sepsis had at that time. But then we did not have any kind of proof. There was no scientific research of this kind of scale at that time. So the symptoms started getting worse following parasitic edentilation. When X-rays were found, it was actually found that it was not a big deal and the periodontal disease could not have caused all this. Animal model research added further further credibility to the fact that periodontal disease may really not be causing other things. And then of course came the advent of endodontic therapy, where they found that a good endodontic therapy was actually curing a lot of things. So slowly this focal sepsis came into disrepute, and in 1996 Dr. Stephen Offenbacher, who is called as the father of periodontal medicine, he is unfortunately not alive now, but he has done a lot of pioneering studies, and he is the person who coined this term as periodontal medicine. So this is a very interesting study. Whoever is interested can look into it. It's not only periodontists, they have painstakingly mentioned all the important studies which have been done in the past century for periodontal disease. But even in this study, in this paper, what they have mentioned is only these three reports about preterm low birth weight, cardiovascular disease and diabetes have been spoken in detail. So periodontitis and CVD, lot of studies have been done to find out whether periodontitis really caused or was a risk for cardiovascular disease. After a few studies did say that there was an association, they started looking for any mechanisms which could be linking the two conditions. That was also found, but one disadvantage was that they all worked on models with only one bacteria, namely Porphyromonas gingivalis. But now we know that periodontitis is a polymicrobial biofilm. So it was not really understood whether, just based on one organism, we can say that periodontitis can increase the risk of cardiovascular disease. So based on that, this is a very pioneering study by Matilla. It was a very simple study which just looked at about 72 case control patients, and they concluded that after all the confounding factors are removed, also periodontal disease would be a risk. So this was the first study. So that's why got a lot of attention, though there were a lot of biases in the study and other things which not need to be discussed here. But this longitudinal study by D. Stefano, so this color coding basically I have given that for cross-sectional studies it's purple and the longitudinal studies it's yellow. So the dental risk, and in this D. Stefano study they did, I think almost 10,000 patients were examined, and they found that almost most of them who were men were 25% more prone to developing cardiovascular disease. This was a kind of landmark study where the risk of coronary heart disease was about 1.3 times. This is a study which was done by me. This was actually my doctorate work where I examined patients in the CCU who had actual myocardial infarction. I checked their periodontal status and I looked for a non-coding RNA called as microRNA, and it was found that the microRNAs in the periodontal disease were influenced by periodontal pathogens and increased. So since I was actually, it was a real-time study. It was taken from patients who actually had myocardial infarction within 24 hours. Okay, so this was a very valid study, and I found that in these 4 groups, the group with periodontitis, the groups were patients who didn't have periodontitis, patients with periodontitis and acute coronary syndrome, and those without. It was found that patients with periodontitis and acute coronary syndrome had the highest levels of this microRNA. Okay, fine. Now there's an association. Are we going to improve anything by treating it? This was a study done by Dr. Mark Hyde, and he said that probably yes, there may be an improvement, but when you do the treatment itself, you are releasing a lot of bacteria. So you may be causing actually bacteremia and short-term risk of increased bacterial, systemic bacteria in the blood. Whereas another study which was done by Tonetti said that yes, there is a short-term bacteremia, but after about 6 months there is an improvement in the endothelial function as well as the cardiac markers. And non-surgical periodontal therapy reduces coronary heart disease markers. So this person found that there is a reduction of the WBC count, the fibrinogen as well as the C-reactive proteins in these patients. Anybody knows what this is? Have you heard of this? Is it associated with what we are talking now or something else? So this masala study is nothing but the mediators of atherosclerosis in South Asians living in America. Okay, South Asians means primarily a lot of Indians. So they wanted to know what are the factors which are mediating atherosclerosis in Indians. So whether them being Indians itself is really a factor or is there other things. So what was seen in this is to discover, okay, of course it also involved Chinese and Koreans and a few others, but majority of them were Indians also and Filipinos. So to discover the heart disease risk factors, to measure the early stages of heart disease, to learn how it develops and to prevent heart disease. Okay, and the findings were that high socio-economic status, so Indians were well placed there, low smoking, low alcohol, very low physical activity, fat composition is high, higher diabetes prevalence, differences in your coronary artery calcium in men, it was very high in the South Asian men, and higher carotid intima thickness and other groups. So why I am mentioning this masala study, though it is not really concerned with us, is that we have to have such studies in India because we are going towards a very alarming rate of getting non-communicable diseases leading to mortality. Periodontal disease and risk for adverse pregnancy outcomes. Offenbacher did a study with about 124 case controls where they found that it was a risk factor for preterm low birth weight. And this systematic review again found that in patients with periodontal disease, yes, they did have a risk of high preterm low birth weight. And another important thing they found was preeclampsia, that is increase of increase of hypertension in patients with who are pregnant, which led to premature births. and sometimes even infant mortality. Rate of preterm delivery, a randomized control trial, they found that in 3 months there was not much of any big difference in the therapy. Okay, fine. Even though why I gave you all these studies is, I know there's a lot of information to take in, but why I told you this is to show the disparity in the different results that have been shown so far. So basically you can do a treatment of pregnant patients in the 2nd or 3rd trimester, but you have to be careful because you are actually inducing a transient bacteremia by doing a treatment at that period. So ideally, do a periodontal evaluation, preventive and therapeutic intervention prior to pregnancy. So these are the things which have to be established in our country. You have to tell the general public, before you plan for a family, you please visit your dentist. So that is the way you can prevent these kind of complications. Diabetes and periodontal disease, I think I have already spoken about this. In this, it was found that in Paima Indians, the study was done. It was a longitudinal study for 11 years, where about 500 to 600 patients were studied, and they wanted to progressively see what disease they died due to and what was the periodontal status in those patients. About 204 patients died, and it was found that most of them who died of ischemic heart disease and diabetic nephropathy were patients who had poor periodontal disease, poor periodontal health. And in this particular study, it was found that when you did a periodontal therapy in patients with type 2 diabetes, the HbA1c levels were improved. That was a very pioneering study. In this study, it was found that it's not only the increase of HbA1c was also reduced to less than 6 in many patients, but it was also found that many of the markers such as your C-reactive protein were also reduced in these patients after your treatment up to a period of 12 months. So I think these are two pioneering initiatives which were taken in India. So long we've been talking about US and Europe and other places. In India, this is a very good initiative taken by one is our Indian Society of Periodontology along with the Research Society for Diabetes, and they also conducted a Perio-Diabetes Symposium where they gave some guidelines for management as far as India is concerned. So pre-diabetics and diabetics have higher chances of developing periodontal diseases and vice versa. New evidence also emphasizes the role of lipid imbalance by cytokines. Improving the diabetic control results in improved periodontal health, and that again helps in improving diabetic complications. Clinicians should have an understanding. First of all, dentists should believe this. I'm not even sure how many dentists believe this. When a patient with diabetes comes to you, it's your duty to understand that they may be at a risk of other diseases as well, and talk to them or refer them to a relevant specialist. And most important of all, a set of practice guidelines must be developed and incorporated as for our own country, not based on American Heart Association or European Diabetic Association. Okay? So we still have a long way to go, but yes, we are getting there slowly. Impact of periodontal therapy on systemic markers of inflammation and patient metabolic syndrome. Yes, a lot of the parameters of metabolic syndrome have improved after this periodontal therapy. So the hypertensive blood pressure levels had gone down, the HbA1c was better. So this randomized control trial gave us a lot of positivity to say that treating periodontitis might reduce the risk of other conditions. This is the latest March 2023 consensus which says that when you do a proper periodontal therapy, definitely it is going to reduce the risk of cardiovascular disease, diabetes and respiratory diseases. But what it emphasizes is the communication which has to be there between the specialists as well as the patient as well as the dentist. Even if you are not as a dentist, as a general dentist, you are not able to treat the patient, you have to refer the patient to a periodontist and make them do the intensive periodontal therapy such as maybe non-surgical therapy or surgical therapy with bone grafts and other regenerative therapies which can eliminate the inflammation and improve the systemic health of the patient as well. Yeah, this is definitely too much of an evidence. Right, left and center studies have been done about periodontal medicine, and this is recently in 2016. A systematic mapping of clinical trial registers in periodontal medicine. Can you see this? It's mind-boggling. These are the number of studies that have been done for periodontal medicine. So sometimes that's what I mean is, I don't mean that all these studies made sense at all. Most of them were not proper. That I'll be coming to later. But you cannot take in this much information. It's like, garbage thrown in. We don't know what to take in, what to take from this. Does it really make sense? So, but anyway, it was a eye-opener because it was a registry which mapped all the studies done in periodontal medicine. But now we should see what are the challenges that we faced in this. What are the gaps to be addressed in this? Methodology. So mostly everything was a cross-sectional study. We have to go in for longitudinal studies and systematic randomized control trials. The case definition of periodontitis was not mentioned properly. Statistics was done very randomly. It was all not following a proper pattern. Effect modifier. For example, a diabetic patient is already on anti-oral hypoglycemics. Cardiovascular patient is on statins. So all those things were not taken into consideration. Theoretical models related to socio-economic conditions have to be incorporated. And the sample needs to be a scope that it has to be divided into subgroups. For example, you say he's a smoker. You have to say whether he's a current smoker or he was a previous smoker. So all those things have to be brought into the picture. Improve the type of therapy. Just don't do a scaling and say that nothing improved. If he needs a surgery, do a surgery. If he needs a full mouth disinfection, do it. A lot of heterogeneity was found in most of the studies. That's why we are not able to come to a lot of conclusion. And the levels of evidence, I think you know very well, this is the US Agency for Healthcare Research have given these as the levels of evidence. So many of the studies, the so-called systematic reviews, did not have an RCT also. They were all based on some random longitudinal studies and cross-sectional studies. So this systematic review showing evidence of the effect of periodontitis on diabetes finally just said that yes, periodontitis is associated with diabetes, but in fact it is the sixth complication of diabetes. I think you all know that Lowe et al. Said in 1986 that way back it is one of the complications of diabetes and not vice versa. So still this systematic review feels that it is not a fact to consider that periodontal disease can cause diabetes, but still treatment of periodontal disease can improve the glycemic control. The same thing has also been said by Prishaw in 2012, where they found that it is a two-way relationship, but management and long-term follow-up is going to benefit both the patient as well as the doctor. This is again something I wanted to tell you. When you all look at studies, maybe it's not very relevant to what I am talking now, but have you heard of something called effect size, all of you, especially the postgraduates or those who are doing studies? No more we are bothered about p-value. Okay, now we all say p-value, statistical significance, blah blah. That's not there now. It's all about effect size. So you should describe the results in terms of measures of magnitude. Not whether treatment affects people, but how much it affects. So whether doing periodontal treatment is going to improve glycemic control. Is it going to keep it like that for a year at least? Is it going to keep it like that for years to come? Or you just do some treatment and for 1 or 2 months they are fine. That's not the way it works. So when you design a study, you have to keep in mind the effect size. So this is again an evidence base that periodontal treatment improves biomarkers and cardiovascular disease outcomes. I think this study spoke more about how the endothelial integrity is improved and the intima carotid artery and the intima media thickness have all improved after periodontal treatment. Okay, now that we are done with a lot of evidence which is still a little shaky, maybe we can talk about last part. We have to look at patient. The third part of my question, how to implement oral systemic care into your clinical practice. Educational materials to educate your patients, give them pamphlets, brochures. You can run all these videos in your dental waiting room for them to understand. Communication tools, I think we all have our social media pages now. You can communicate very effectively on that. Telehealth resources, and talk to them more about the environmental and lifestyle factors like having a good diet, not smoking, and to have a more active lifestyle. All these things can definitely go a long way in improving the patient. Preventive approach is to have good diagnostic tools. Go to everything at a very preventive level. It should be caries prevention, periodontal disease prevention. Probiotics now play a very important role. This Catewell strain comes from Streptococcus salivarius. It is found to be very effective as a probiotic. Most and vaccines, of course, is still a grey area, but it's still being researched upon. Collaboration with systemic health professionals can be a very good preventive approach. So when you feel that your patient has periodontitis, immediately ask him to get his blood sugar checked, especially when he has the other risk factors. He's an obese patient, he has a sedentary lifestyle, he's a smoker. Yes, definitely it should occur to you that you have to refer him to a doctor and get him checked for diabetes. Similarly with cardiovascular disease, therapeutic approaches, if you know the patient already has a problem, do a customized treatment planning, regenerative therapies with associated drug therapy. What are the future perspectives? This is a buzzword now, P4 medicine. How many of you have heard of it? It's a future now. Okay, what is this P4 medicine? It's a precision medicine which is focused on the individual and not on just the disease entity. Okay, even if there's A, B, C, D, 4 of them have diabetes, they all have to be treated differently based on these perspectives. Predict, prevent, personalize and participate. So personalize is the key word here. How do you enable this P4 medicine? You should have interdisciplinary and collaborative research. So when you do a research on a diabetic patient, you have to involve the diabetologist as well. Okay, it's not only the oral team which has to do the research. These are all proteomics, metagenomics and metabolomics are all various research entities which are going to decide the various markers which play a role in causing certain diseases and which can reduce the incidence of certain diseases. Maybe after 10 years, all your tests, HbA1c and everything will come as a chair-side test. You can just with the prick of the needle, or maybe even better as dentists, even with saliva, you can have these kits, and on the chair you can tell the patient, yeah, see, you have a high HbA1c, you better watch out. Patient education and engagement can happen in various ways. Vaccines, artificial intelligence, I think this is not the future. This is even happening right now. You know, there are a lot of apps which you can connect. You can tell the patient, yes, this is what you should not be having this. The moment your blood sugar raises, it will show up in the monitor. A lot of things are already there now. So not very far is the day when we can do this even for our dental patient. You can say all this is there. This is your risk calculator for developing cardiovascular disease or diabetes. Okay, so that day is really not too far. So this is probably the roadmap which I can say towards P4 medicine. A lot of research is going on in the various omics. So you correlate your clinical and risk factors, then you have an ID. Like all of us have an ID, you have a periosystemic ID and you will be able to have a very successful, integrated, holistic approach towards treating your patient. But of course, based on the pace of scientific discovery, there are a lot of other drug regulatory approvals, and adoption of newer technology. So everybody should first agree with this. They should not be resistant. It should be accepted by the dental community. Only then we can do something about this. So at the end of the day, yes, maybe there is an association, but this picture which you see here is absolutely scientific. Okay, so you have healthy tissues, you have homeostasis. On the other hand, you have unhealthy gingiva. It can lead to a biofilm dysbiosis leading to a lot of these conditions. So healthy diet, healthy oral tissues, maintain a good systemic health. Otherwise, unhealthy diet with high carbohydrate, especially which is prevalent in our country, can lead to increased psychological stress, elevated cortisol, increase in the level of severity of non-communicable chronic inflammatory diseases, which becomes a vicious cycle. So I hope I have to take a leaf out of this. I know it was a very exhaustive presentation, but at the end of the day, you should know how to approach your patients based on the current science that is available to you. Thank you for your patient listening.
Thank you so much, ma'am. You have taken a lot of effort to cover such a big, vast topic and give us a comprehensive review of the entire periodontal medicine facets. And thank you wholeheartedly. Any questions from the audience?
Yeah, I do have a question to ask, just a comment. Regarding your suggestion on pregnancy and periodontal disease connection. So I'm right now working in Brunei, and over there, what they're doing is for pregnant women, they give an antenatal booklet to them, and in that there's a dental chart included. So they have to mandatorily get dental checkup done during their pregnancy, preferably in the first trimester. Because you don't know, you can't plan your pregnancy or anything. It's not like that you are planning and then you just go for dental checkup. So when I think that's a good method, that when you are pregnant, you automatically are in the system, and so dental checkup is kind of mandatorily done. And so that is like a very good method, I think, to prevent periodontal disease. Probably in our institutes or in our state level, in our Ministry of Health, we can recommend something like that.
Health policy, right?
Yeah, so something like this, just a suggestion.
Yes, definitely, it's a very valid suggestion. Yeah. Only that probably the preventive aspect also can be, they should be sensitized. Exactly.
Thank you, ma'am. With that, we'll wind up the session.
Thank you so much, ma'am. It was a wonderful presentation. I like to call upon the Rija and then Aruli to deliver the memento to the guest. I'd like to call upon Benin sir and Gopala Krishna sir to give the memento to the moderators. Moving on to the next session, I'd like to call upon Shalini Gupta and Shrudish ma'am to be the moderator for the session. I'd like to introduce the Shalini Gupta ma'am. She done her BDS and MDS in GDC Ahmedabad, the gold medals in KG, MU, Lucknow, forensic. As well as she was the professor and head of oral pathology, PGMU, Lucknow. And she has done the molecular genetics and cytogenetics in oral cancers and genomics. She was with membership in MNAMS, FICE, and she was done a scientific award for ICMR. I'd like to call upon you, ma'am, and thank you for being the moderator. And I'd like to introduce the Suhees, which is the professor and head of the prosthodontist of PMS Dental College and associate dean of the PMS College. Yes, thank you, ma'am, being the moderator. It's my privilege to introduce Namita Shambak ma'am. Welcome ma'am. A mild career woman of dental professional graduated in the year of 1994 with a postgraduate degree in public health dentistry from a well-known health university in India. She was close to 25 years of experience in academia involved in the supervision, advice and training of undergraduate and postgraduate students and professionals in the area of preventive and community and public health dentistry, also providing the overseeing direct dental diagnosis, treatment and procedure affordable to the dental care. And she was nominated as a fellow of ISDR during the 31st ISDR annual conference of Navy in Mumbai in 2018, and also nominated as a Women Dental Council member from the Indian Dental Association Bangalore from 2018 to 2019. My interests lie in the Med-ART and Population Oral Health Tobacco Association and the electronic dental records. I'd like to welcome you, ma'am, to deliver this speech.
Thank you so much. I think we are at the fag end of the day, and I see only impatient faces, including me. So, thank you organizers, and thank you moderators for being here. At least you could be here on time and we could finish this session successfully. Thank you one and all. We spoke about, I think that was a wonderful session by Dr. Geeta. In the end, Madam was talking about something called as P4 medicine or precision medicine. So this will be my core topic of today's talk. So what is happening in dentistry today? I'm talking to the generation Z, Gen Z, isn't it? So all of you are Gen Z. So what the future lies ahead? What is in store for you in dentistry? Is it implants? I'm just asking you. Are you interns? Yeah. So some of the advances which you are going to be seeing in my slides will be the future of dentistry. So I'm just introducing you to some of the recent advances and what is going to be like in future and what would you be practicing later on in life as a dental practitioner. So the topic which I have chosen is revolutionizing oral health, an introduction to precision dentistry, e-health, and what is the data-driven future that we have today. So the topics would be covered under following contents. Something about AI, which all of us are using. In the morning you saw about Dr. Arunachalam talking about digital dentistry and what digital workflow he used in preparation of a crown in minutes in his practice. So why there is a need for transforming traditional dentistry? And we know that throughout the course of history, humanity has witnessed a remarkable improvement in the general state of well-being, and there is notable advancements in human health. And you know that the lifespan of individuals have undergone a significant expansion. So we have the technology and medical advancements which are doing this progress in improving our lifespan. Can I have the audio visuals? Yeah, the significance of maintaining good oral health and preserving our natural teeth has become increasingly evident. And a pivotal factor in contributing to this phenomenon is what has been done in the field of medical technology. What are the advancements? If you look at a broader scope of medicine, there are a lot of advancements. There's personalization of healthcare. And when we look at dentistry, we also need to be aligned with these changes, which we could have an enhanced overall patient care and outcomes. This traditional dentistry, what we are practicing today, may not capture the unique aspects of each patient. As Madam said, P4 medicine, individualized care, that cannot happen in traditional dentistry. So we need to move on to a precision-based dentistry. So traditional approaches may lack the sophistication needed for accurate diagnosis and targeted treatment. So precision dentistry leverages, it makes use of all these advanced technologies like genetic testing and imaging and aid to personalized dental care. So good oral health is not just a matter of routine dental checkups, it's a cornerstone of our well-being. So today let's embark on a journey to explore how revolutionary advancements in precision dentistry, e-health, and the power of data are shaping our landscape of oral health care. So what do you understand by technological innovations which we have already seen in dentistry? We have digital imaging, we have digital x-rays and intraoral cameras, and computerized assistant aided designs, that is CAD/CAM. And we know that how teledentistry was used during COVID and how useful it was for the mankind. And next slide shows 3D imaging, which all of us are using today in practice, and how treatments are simulated and how precise measurements can be used by using these technologies. So what are the key benefits of digital imaging? It allows for extremely precise scans and measurements of teeth and jaw. It helps in personalized treatment strategies. That is what we are looking at, individualized treatment plans. And when you talk about digital imaging, we'll have beautiful clarity on what is there in the scan, and it will aid us in accurate diagnosis. So coming next to what is e-health? We are talking about everything is E. Everything at your tip of your fingertips. E-health is reshaping the landscape of dental care, from digital imaging for precise diagnostics to secure electronic communication. E-health is fostering more efficient and patient-centric approach. What is e-health? E-health leverages digital technologies like mobile devices, softwares, and the internet to improve healthcare services. We have health information. E-health manages health data like electronic health records, test results, appointment info, and patient monitoring data, everything which can be done at your fingertips. And it improves access to healthcare services through telemedicine and remote patient monitoring and online portals. What kind of data which we could think of having? We have dental x-rays, we have intraoral images, we have CT scans, we have digital photographs, we have the dental charting which we use as a daily record. We have prescriptions and wearable sensors, which I think we spoke about Colgate having a toothbrush sensor. So all these things are already there, and how are we going to use it in our daily practice? Is it because of, what is this? mentioned about depending on technology. This is the disadvantage of technology. So just to give you a history of e-health, is getting another connector. There was this launch of the first telemedicine company in 1999 called Amwell, and then later on we had WHO coming into picture and calling the name term e-health. Okay, and then it went on to the US acting upon an act called as High-Tech Act to promote adoption of electronic health records. And in 2020, telehealth usage surges during COVID epidemic and pandemic. And 2020-2025, WHO comes with a document which talks about e-health and prevention. Is there a major issue?
இப்பதான் முடிஞ்சா
Sorry for this. I believe Apple has always been famous for these kind of interruptions. So what are the benefits of e-health? We have improved accessibility, increased efficiency, enhanced accuracy, and better connectivity. For example, what is e-health in action? So doctor using a telemedicine system, patient using a health app, and clinician using a electronic health record. So these are the applications of e-health today, what we see in day-to-day practice. When you look at statistics from 2022 Global e-health report by WHO, India has 51% of youth adopting e-health, Germany has 65%, and United States has around 72% adoption rate. Who are the industry leaders? We have NextGen, e-healthcare, and Allscripts, to name few. What are the challenges here? We have patient concerns, we have interoperability issues, data quality challenges, cybersecurity threats, regulatory compliance, and clinician buy-in. So people, the clinicians have to be updated with latest technology, and they have to go in for such products. So coming to the next advances, which we saw in the morning, that was a smart oral device. What are these? These are sensors which can be used by patients, and they monitor your health. So some of the conditions that can be monitored are cardiovascular health, respiratory health. All of you have an Apple Watch which can detect your heart rate, blood pressure, maybe or sometimes not. It can monitor your breathing patterns, and it can also detect conditions like sleep apnea. It can track glucose levels, and it can also analyze your nutritional intake. And when you talk about oral care hygiene and how are these going to help us, what are these sensors and how are we using it? And today we had seen a Colgate sensor. So these smart devices are exciting emerging technology with many potential applications to improve health and quality of life. You can see a wearable, which is a watch, and you can see a mouth guard, which has a sensor. What does this mouth guard help you in? It has been proven and it has been used by sportsmen and sports dentistry to track the occlusion and occlusal pattern, and also in treatment of concussions, the head injuries sometimes which they treat. So these wearable mouth guards are having sensors which detects pattern of healing. So this was the key line of some innovations. The Oral-B was the first one to have an electronic toothbrush with Bluetooth connectivity, and then came with Philips. And in 2020 it is Quip, which launches the smart motor app, and today we saw in 2024 the Colgate launching its sensor brush. So these were some of the oral health devices which are using today. So this, if you're talking about a toothbrush, it tracks brushing habits like pressure and motion. If you're looking at another brush like Bean brush, it also provides personalized feedback that you have brushed properly or not. And if you're talking about the mouth guard, it tracks teeth grinding and it tracks clenching. And also this intelligent mouth guard, what is shown in the picture, is equipped with sensors to measure linear and rotational head movement in real time. So these are used by sports personnel. So by using these, we have improved oral hygiene, cavity, we can prevent dental caries and also prevent gum disease. So when you're talking about, for example, if you're talking about blood glucose levels, when you use smart oral device, the accuracy is around 95%. It can monitor blood glucose when compared to blood tests and wearable devices. So smart oral device is going to be the future of monitoring blood glucose. So when you look at the next topic which I was talking about is, as Madam said, we are talking about an overview of how advanced technologies are enabling personalized dental care, or P4 medicine, how collecting and analyzing data is driving insights, and just a preview on how emerging technologies like 3D and AI are going to be the future of dentistry. We saw about P4 medicine, which Dr. Geeta was talking about. It is predictive, preventive, personalized, and participatory. So this is why this was way back 20 years ago proposed by Leroy. And it's a precise and personalized, also preventive and participatory care facilitated by a range of factors. What are the range of factors? We have digital technologies, and we have system medicine and data provided by patients. So much of data is provided by the patients and other social networks, and also we have data regarding the risk indicators. Altogether, we have something called as P4 medicine, and precision dentistry follows the steps of the P4 medicine. It refers to tailoring a therapy to an individual. It is an individualized patient. Like all diabetics cannot be treated uniformly. So we need to take care of his or her biological genome, genomic, microbiomic, or proteomic, plus his social, that is social factors, which are economic and educational factors, and also behavioral, lifestyle factors, allowing to predict the traits, how this individual may react to your therapy. And this is what we are looking at in precision medicine. And this is also used in dentistry. So a dentist uses an intraoral scanner to get a 3D model of a patient's teeth. A dentist reviews the patient's dental records and x-rays on the tablet, and the patient receives a 3D printed custom dental implant created from their CT scan data. So all these are possible today. So what is it going to happen in the future? So this precision dentistry is an emerging field that leverages advanced technologies like 3D, imaging, and artificial intelligence and robotics to enable dentists to perform highly customized, minimally invasive treatments. So the goal of dentistry is to provide accessible and affordable healthcare to all. So this is what is going to be practiced. So with the help of precision dentistry, we have enhanced imaging. So genetic testing will be the norm, and biomarkers, detecting biomarkers in saliva to enable early diagnosis and conditions like cancer, which was the first talk of the day today. Dr. Nikra Madam had spoken about saliva as a diagnostic tool. So this will be the norm in the future. So precision dentistry and diagnostics will lead to personalized treatment plans. You can follow or you can practice preventive dentistry. This will improve the patient's education and enhance patient engagement and improve your practice efficiency. So when you look at that, it also aligns with precision medicine, which we spoke about, that P4. So it identifies the genetic factors behind oral health status, explore the biological pathways of disease process, and utilize biomarkers in diagnosis and prognosis. And it considers patient-specific phenotypes that may impact the outcomes of your treatment. And it can provide tailored and evidence-based intervention based on personalized characteristics. So, but what are the challenges in this digital oral health data and precision dentistry? So much of data is available. So what challenges do we expect? It is the regulations around medical devices and healthcare that make rapid innovation difficult. And data privacy. So we all talk about ethics and we talk about our data being private. So this is one thing when you look at the future. So this is an important aspect where we look at collecting and analyzing oral health data raises privacy concerns that may be addressed responsibly. And then consumer adoption. Not all will adopt to this. So getting consumers to adopt to new oral health technologies may require education and a behavior change. So lack of standards. There is no widely adopted standard for structuring and exchanging oral health data. And privacy concerns, the costs, as morning Jyoti sir was asking the speaker, what is the cost of including this digital workflow in your practice to make one single crown? So integrating with workflows, it might not be easy to integrate all the systems that you have with your older systems. So integration of old and new technology may take time, and that can be a setback. So to improve on this, we have training programs, we need to have incentives, we have to have peer support. Like today we had a lot of lectures on digital dentistry and continuing programs like this, pilot programs, and we need to address these concerns proactively. So what are the opportunities? We can do preventative treatments, we could do early detection with the help of AI and robotics. We could give personalized care to our patients, and it could be an accessible care and include patient education, and we could involve ourselves in holistic wellness. So this is the thing we are looking at, empowering dental practitioners and researchers, synergy of precision dentistry and data science. This is what is going to be the future of dentistry. The integration of technology and precision medicine is revolutionized how we approach oral health care, tailoring interventions to individual needs. So which are the key technologies today we are talking about? We spoke about digital dentistry, it is in practice. We are talking about artificial intelligence, some of it is in practice. We are talking about 3D printing, we are talking about robotics, and we are talking about digital scanning. Along with this, we are talking about what is e-health data science. It is not only e-health, it is something called as e-health data science. It is the application of data science techniques. So here the engineering principles of computer science and artificial intelligence come into picture. So what is this? It comes from various health records that we had seen already, and data sciences utilizes statistical analysis and AI, namely machine learning, and we have natural language processing, data visualization and other techniques. So in dentistry, e-health data science can enable precision diagnosis and treatment to predict oral diseases and optimize practice outcomes. It can improve patient outcomes, it can reduce costs and advance dental research and knowledge. So we are looking at something called as data-driven science, that is e-health data science. So coming to artificial intelligence, all of you are using, and we are looking at the concept of AI, which was introduced way back in 1956. It has grown rapidly. It is used in autonomous automobiles, it is Internet of Things, medical diagnosis and healthcare. So what are the various programs in AI? We have methods like machine learning, deep learning, natural language processing, and it uses big data, we call it data mining, and profiling of NLP. It uses neural networks to generate connections mimicking human communications. That's why it's called neural networks. So what are those neural networks? We are looking at neural networks such as CNN. Anybody has heard? CNN networks? GAN? No. You have heard ChatGPT. Convolutional networks. Correct. So what are the other programs which are using day to day? We are having many programs which are often on your fingertips, that's on your mobile or any other computer program. We are looking at something called as NLP, and one such program is ChatGPT. It's a chatbot, a computer program designed to stimulate conversation with human users, especially over the internet, that has evolved to generate responses to a question in a human manner. The picture which I posted here, the image is from a ChatGPT image. So I asked the computer to give me an image of a e-health data science, and with related to oral health. So this is what I get. So machine learning and deep learning in dentistry is a huge thing now, and we are all going towards that end. So we have X-ray image analysis, 3D imaging and cavity detection being so easy with the help of AI. And when we spoke about CNN, it helps in diagnosis, okay? And it improves the diagnostic accuracy. When you look at CNN application of AI in detecting dental caries. So the overview, I'm just brushing up because we have a meeting coming up. So we have an overview of AI in dentistry. It helps in diagnostics, it helps in treatment planning, it helps in robot-assisted surgeries, and it helps in process automation. Again, ethical concerns in dentistry. We have patient privacy, we have to take informed consent, and biases and fairness and accountability is very important. So, what is needed? Research is needed in oral health informatics, more randomized trials, more implementation studies, and studies across diverse populations. And ongoing education for the Gen Z and the older dentists like us with regard to AI and other things which are revolutionizing our dentistry. So the future digital dentistry is AI and ML algorithms used for accurate 3D diagnosis. There will be nanorobots printing used to regrow teeth and repair cavities, and tooth decay and gum disease can be reversed and prevented by gene therapy. This is going to be the bread and butter of future young dentists. So conclusion, data science has the potential to transform dentistry by enabling more personalized and preventive care. However, it is critical that we implement data-driven dentistry responsibly with careful consideration of ethics, privacy, bias, and other potential harms. Just to conclude, I'm just taking you through a movie. It's again a AI picture. You awaken in the middle of the night that the tooth has been little sensitive and probing. By morning you realize the real problem. So you go to your bathroom and use a sensor brush. And what happens? The sensing brush senses scans your teeth. And the images are automatically uploaded in the cloud. It is happening now. So where it is analyzed via artificial intelligence, which finds a cavity in your aching tooth and a hairline crack on another molar. Okay, and these scans and preliminary analysis is sent to your dentist, and you go to your dentist next day. So what happens? The dentist removes the decay. It's already diagnosed. So he removes the decay that is etched into your cavity with a laser. So there is no Novocaine or Lignocaine, and he treats the cracked tooth, and he says that it would require a crown. What happens there? The office technologist comes and does a 3D ultrasound of the two problem teeth. He takes the x-rays. Dental drills have become a thing of the past. He just takes a scan and sends it to the lab. And one robo instantly mixes the biologically active restoration to fill the cavity. But it's not like old-time silver amalgam nor composite. It uses stem cells to build your tooth's dentin that is lost due to cavity. And the second machine prints a 3D printer, manufactures a crown of the other tooth while you wait, which your dentist pops in right into without the need of adjustments, because it is so precise that we don't need to take the measurement, take the occlusion and all that. So these procedures that once required multiple visits are completed in just 1 hour. So the night you have pain and next day you have a cracked tooth filled and you have a dentin repaired and you have a crown done in 1 hour's time. So this is the era of dentistry that you are going to be working on. Sounds like a scene from a Star Trek. It's actually a peek into the future of dentistry, says Larry Emmont, a dentist, and he's a dental technology expert. So much of this, I think, is possible within the lifetime of dentists practicing today. So with this, I conclude this presentation and acknowledgements. Thank you for the 34th ISDR team for giving me this opportunity. I thank the team members of ISDR and also all my support from GDC, my Public Health Dentistry Department, Dr. Manjunath Puranik, and all my faculty members and my interns who are here patiently sleeping and listening to me. Thank you so much.
Thank you,
moderators.
For taking us to the era of the digital dentistry. And definitely it's the need of the hour and we can see it very soon. Even I saw that, just to add to your this thing, they are making robotic hands to do the scaling and other treatment procedure. It may be replacing the budding dentist also. So one way it is good, it is fine, you are getting, it is speeding the procedure, getting accuracy, precision, like precision medicine for oral cancer. That is also true, that is going to remove so many toxic effects of all the combinational therapy. And so one way everything has a pros and cons, as you said, technology. So let's hope for a better future. Thank you.
Madam, you really took us deep into to the future. The youngsters here, they will make use of it. Hope so. Let them. Thank you. It was a wonderful presentation, ma'am. Thank you.
Thank you, ma'am. It was a wonderful presentation. I'd like to call upon the Shali Gupta ma'am as well as the Sughi sir to give away the momentum. To give upon the momentum for the moderators.
Thank you so much.
Sir, please.
Thank you, one and all. The keynote sessions are over. Now we give the guys to the AGM meeting. So the ISDR members can be retained, other can be going to the respective places.
Back lot adega.
This 34th is coming. The 34th is coming. That's why. ಹೌದಾ
this is the AGM notice. I've already sent the hard copy to everybody. Still, I've brought some copies. Good evening. Welcome to the 34th Annual Conference and the 34th AGM. I have a great privilege in honoring. Unfortunately, our President, Professor Mahesh, is not well. I think today he is discharged from the hospital, and wishing him good health, speedy recovery. And I look for your consent to call our first Vice President, Professor Vijay Mathu. We have, I think, around 25 people. Arvind, Ilan Kuruma, Alex, I request our First Vice President, Professor Vijay, to give the presidential address.
Dear members, thank you very much for giving me this opportunity to speak in front of you. Much has been spoken about ISDR yesterday. We are committed to continue the good work. Some of the major decisions which have been taken by EC for promotion of dental research and for promotion of ISDR shall be discussed today. So I welcome you formally to this AGM.
Thank you.
So we request everyone to please sign on this register and write your name clearly, legibly. Earlier in one of the meeting we could not read the name of the person, so how do we establish the attendance? That was a problem. Last AGM we had 36 people attendance, today it is a little less. Let's see how many actually. I remember giving you the. So the previous AGM minutes were circulated.
Ikku and team, they are not here. Okay, ask, get the signature, okay? Please here. So, it was already sent, and the EC we have passed the previous minutes. And you have any objection in passing the previous minutes? May I take somebody to propose and second? Dr. Bala Gopal sir, Jodhindra Kumar sir. Next is the editor's report. Actually, editors, my daughter is doing the job. She has come from Chennai. She will be there. Just give the salary briefly. You don't need where it is.
Good evening. Good evening, esteemed members, colleagues. It gives me great pride to give the report of the IGDR for 2023. I thank Dr. Anil Kohli for giving me this opportunity. I also thank all the EC members for the great support for the journal. For 34 years, IGDR has been a hub for the dental research. And since going online from 2007, we have connected to almost to the researchers globally. And so right now our research gains visibility as it's indexed in the DOAJ, Embase, PubMed, Medline, and Scopus. We are also linked in other platforms like Google Scholar, CNKI, ProQuest. So this enhances our impact. Our strategic approach in the journal is focusing on 100 to 120 impactful manuscripts annually, and this strikes a great balance for the journal. And optimizing costs while upholding the standards is important, and we're working on that. So our positive citation trends can be seen. It has surpassed 2002's trends, and our research is prioritizes high quality because our H index has grown from 29 to 32, and our H5 median has increased from 38 to 49. This emphasizes our research over volume. And our SJR ranking has also it's rising, and this is attracting a lot of global submissions. And to enhance the excellence of our journal, we are minimizing the articles, we are minimizing the case reports, and we are only keeping original articles. So our website has been revamped, and it has become mobile friendly now, and that's really helpful for all the members and for the people who are using our mobiles, and it's really reaching the people. So our global audience, 133 countries are using our website, and 3,565 cities, and India, USA, and Egypt are leading in the reading. So other challenges that we are facing that the ISDR forum needs to help us with. So the conference fund shares. Since 2018, the conferences have not provided any funds for the journal, but last year Professor Mahesh Verma has reversed this trend, and we hope that this year also, this conference, the organizing team will be able to continue with it. And publication costs are rising. We are still not printing the journal for all the members. Other subscription complexities are there because this year only 8 colleges have subscribed for the journals. We hope that all other colleges in our all of our members will be able to convince your colleges to put in subscriptions. Maintaining a balance between the reviews and time is very crucial for IJDR, and finding proper reviewers is a little difficult right now, because when we, in 2023, out of 1026 articles, we had 52 new reviewers from 108 countries. In that, 38% of the articles were rejected. Only 3% were accepted. Currently, 58% is in processing. And each article had 5 reviewers, but only 1 reviewer has responded. So we request this forum to identify potential reviewers, advocate for peer review, and we request the seniors to lead as examples for us. And we actively implement solutions for optimizing costs and advocating for direct subscriptions and alternate revenue streams. Looking ahead, we invite collaborations for high quality research, advocate for subscriptions, and support new models. Together, IJDR remains a beacon of excellence, guiding us towards a healthier future. Thank you.
What is the impact factor today? IJDR impact factor.
I'll just check it.
It's below 1, sir.
Below 1. If last year it was about 3, minus 1.
Thank you. Thank you, sir. Thank you, Dr. Anil Kohli and Dr. Preeta. And I request our editor the treasurer, very important. Yesterday we had a very long discussion about the money and the profit and the money which we have. And Dr. Kohli gave many ideas. And I think it's better we go through the auditors, our local auditor and the Delhi auditor.
Yes, a very good evening to all the senior members and other EC members who will be here. So before starting my report, I would like to place on record thanking Dr. S. M. Balaji sir and his team members for helping me bringing this report. So thank you, sir. So as of now, the consolidated statement of ISDR, IJDR and 33rd ISDR conference, that is a statement about income and expenditure account for the year ending 23 March. So this year we received a membership of more than 100 members, which generated around 10 lakhs, and fellowship award fees of 65,000 was generated, and royalty received towards the journal was around 20 lakhs. And article sponsors another 60,000 rupees. Then we had bank interest of 1,08,000. And from the conference people we had 62 lakhs and 80,000 rupees. So we should give a big hand to the last conference members. It generated 63 lakh rupees. So the cash and bank balances as of now what we have is 71 lakhs 83,000 rupees. It is a consolidated statement. With regard to ISDR, we have around 48 lakhs 67,000 in cash and bank. With regard to Indian Journal of Dental Research, we have a cash bank balance of 8 lakh and 4,000. And the profit which was made in the last conference, 33rd ISDR conference, was around 26 lakhs 33,000, of which yesterday morning they have deposited around 20 lakhs to the head office. So in total, we have around 71 lakhs and 83,000. Thank you.
Thank you, Dr. Kishore. Usually, I'm sure Professor Balagopal is here, Sir is there, Jodhinder Kumar. Those days, earlier days, we used to deposit as a fixed deposit. Since after the founding members are here, what happened was nearly 20 28 years we didn't pay, we didn't separate the accounts. And the AGM notice was not given to the government. There was no audited account. And tomorrow we are going to honor Professor Bala Gopal, what work he has done to separate all the things, especially the accounts, and we have paid around 28 lakhs fine to the government to separate all the audited accounts. Now everything is set. Now it is the decision of the AGM to whether we keep the money in normal SB account or we shift the money to the fixed deposit. Yesterday we have discussed in detail about this. Dr. Anil Kohli gave a very important idea that we are going to write it and put it forward to the auditor. If the auditor suggests, then I will write to the EC. Then if every EC member agrees, then we will decide about.
So idea was like such a huge amount, and even the interest which you get on that day, a huge amount of tax goes away.
30%.
30%.
1.1%.
Yeah. So I suggested some out of 71, 50 lakhs should go to the fixed deposit so that it is safe. 20 lakhs which is in the current account or whichever account you have a flexi account, which you should have only 2 or 3 lakh rupees which is available to you. Whenever it goes down, money automatically comes. Whenever it goes up, it automatically goes into in the process, you get the interest. And which interest is almost the same like fixed deposit. And you don't lose the interest when you break the FDR. There you need not to break. But in that case, head office is also at least think twice. The moment he thinks going expenses high or low, because that 50 is fixed, and then another 20, whatever you have out of that 23 or whatever office thinks better, they require for the day-to-day working or the journal and other things. They can keep it, and then bank can be written to them that you shift over to the flexi account, automatically they transfer or they take out the money from that, and you keep on getting the interest. And in the long run, if you see right now it is 70 lakhs, next year it will cross the money, the road and all. So the best way to do the thing is you invest, making in some office, so that property will increase. This money will you get 1-2%. In endodontic society we did the same thing. For 1 CR we bought a office. Now that office has become 1.5 CR.
We have a PAN card now for ISDR, isn't it?
Yeah.
We have a PAN number, everything.
Everything. And we pay very heavy taxes.
Yeah. From my experience in Indian Board of Orthodontics and Indian Orthodontic Society, we have something like 6 crores in the bank. And the entire interest amount is taxable at 31.3%. So what they have done is Indian Board of Orthodontics, they have announced a lot from the interest that comes out from this corpus fund. Lot of free benefits are given to the members. Like everybody gets free journal subscription to Journal of Clinical Orthodontics, all that. So it is totally tax free. They have planned it in such a way with the chartered accountants that the interest amount is used for running the society so that it doesn't become taxable. If it remains there, 31.3% tax will automatically be deducted. So I request senior people like you to consult a chartered accountant, take a written opinion so that it is on record, and do some financial planning for this purpose. In this regard, I need to make one small.
I will request you. Can you give us a little brief how it can be done?
Actually, our secretary is in Delhi only, Dr. Sanjay Ram. He is excellent. You ask
the president. He was here yesterday.
Yeah, you can ask Puneet Patra also.
Sir, your secretary is here, sir.
Previous secretary. He also knows Deepak Chandrasekhar. You can tell him how we did the tax planning and the interest amount.
He is the second vice president, sir.
Incidentally, since we have so much of money, I have a small request to you. Maybe you can take it up in any other patrols. I am one of the old members from 88. I do not know many of the younger people here, but I would request you to give a membership card, life membership card with the membership
I
card.
support.
Yeah, so that everybody who comes to the general body, you can verify. We also feel proud that I was a member since such and such a day.
Not only that, the other one.
One more thing I have a suggestion is we should have a nice label so that we all know that we are members of ISDR. And all past presidents who have been there. Yeah, so if you give a past president, one small thing on below that with a label pin, past president. That's enough. Something very
It will be done,
simple.
sir.
It will be done. It is very dignified. I saw the slide.
And we should also congratulate the members who have truthfully given the money from the conference to ISDR. Give us place on record our sincere appreciation for that. Thank you.
Thank you, sir.
Can I have one suggestion? As Dr. Jitendra Kumar told, I am of the opinion, whatever interest we generate, we should promote and use that money to give the incentive to the students who are involved in the research. We should have no research awards from the ISDR. This is my view.
Sir, I have a solution. So since we have a good amount of corpus with us, can we again plan the tax consultant, then we can invest it somewhere into some tax-saving mutual funds?
I think
those are better results.
We have asked already to auditors to advise us. Tax people should advise.
So no, but we should be open to mutual funds as well, because these days even
as the law permits.
No, you right.
As the law permits.
Whatever sir said.
One more thing, can I clarify?
Please, sir.
Our Indian Society of Dental Research, is it registered under the Charitable Society Act?
It is under the, yes sir, it is registered in the Tamil Nadu.
That is under the Literary and Science Organization of 1956. That will not give you ATG exemption. If you need ATG exemption, you have to register yourself as a charitable body. And you should prove that there is charitable proceedings. So please ask a chartered accountant.
ATG will only get
It has to be a charitable society. We have not registered. And it as a registered charity, so we can receive money free of tax also in future.
Paying a huge tax, sir. This is a very important point, sir. What sir is saying.
Let me clarify. This is registered under the society. And we have paid for 30 years all the tax, previous tax. Now it's fully registered. Only thing is it's not registered as you have registered.
See, in future, there is a provision in our Income Tax Act that anybody who wants to donate towards scientific research and charity,
that is free of
supposing somebody gives you 5 lakh rupees, they still have to pay 30% tax on it. Whereas if you get ATG exemption, it comes free of cost for him and for us.
Sir, one minute, sir. 1 minute. I would like you to note down sir's point. One is he suggested that life member card should be given. The second point, able pin. Third, the past president. And now he has added. Rajesh, you have any idea about this? What sir is saying about the charitable
Societies Act.
See, what we have registered now is the Societies Act of Tamil Nadu. But what Professor Jodhindra Kumar says,
ATG exemption.
is it possible? Then we have to ask the auditor only, sir.
I think auditor can.
Yeah,
Okay, sir.
professional consultancy and do it as well.
Thank you, sir. Sir, somebody can propose the auditor.
Takes the bite.
What happened is, during Dr. Samara's time, they started a small clinic like in Vellore, in CMC Vellore. Based on that, the organization is doing some charity work, then you can get this some hospital somewhere, ISDR is doing some charitable work, something, then you can apply.
Anyway, let's look the formality and let us try to explore them.
Not realize where of course
There is a very good
Shantanu.
So let us explore and find out the way.
Yes, sir.
Thank you, sir. Suppose somebody propose this treasures.
Sir, I have one more thing to say. So, congratulating the efforts put in by the 33rd ISDR, they gave us 20 lakhs. They retained money of 5 lakh rupees as seed money for the next year's conference. I would like Dr. Vijay Mathur to please brief on that.
You got the point, sir?
Sir, but as a body and we are growing larger, tomorrow you may be there, I may not be there. Best is to have an audited statement of accounts duly certified by an auditor. It is being done every year. So, please say that you have received the closed accounts and the money, and then you issue fresh from them, because don't mix both.
Sir, what is it?
Vijay, then the entire profit has to be transferred.
I'll explain.
So in that case, so I request the 33rd ISDR conference members to fully deposit the profit what has been generated.
Only on book because
Assessment is required, but
not
chartered
money
accountant
transfer
statement
because
is
that creates problem for you. No.
Yeah, we understand. Let it please, sir. Let it please.
book adjustment.
Sir, I tell you the practical problem. And we have documented everything. Documented that 25 lakhs profit is being given. Out of that, 20 has been transferred. 5 lakhs is actually a refundable loan to start the proceeding for the next ISDR Asia Pacific Regional Conference. So it is a loan from the head office.
We have also gone through all these travails and tribulations. My only suggestion is, you can say book adjustment. On record, the chartered accountant will give a certificate for 25 lakhs and the profit being transferred. And you in turn will give a certificate that 5 lakhs can be retained by them out of this as seed money.
Yes, sir.
So the
that we talked already.
It's a book adjustment.
Yes, it will be done. It will be done.
Only book adjustment.
Yes. In our minutes also. In our minutes also and with the auditors also.
I agree. I fully agree.
That is a very valid point Sarah said. We must, next meeting onwards, I suggest, we must distribute the